Okay. Well, good evening, class. Hope you guys are all doing well. We are at the Parkland Hospital with Dubuque, and Dubuque is me. Yes, we are here at the Parkland Hospital, and we are going to be caring for Mr. Bryant this evening. And the ESPH Hospital Network has so graciously decided that they are going to record these sessions so that we can play them during class, and you can all get to be a part of the Parkland Hospital with starring Mr. Bryant and, of course, me, Dubuque. And this is the ESPH Hospital Network, the Exceptional Superior Profound Hospital Network. Thank you. Well, Mr. Bryant, come in to see you this morning. I know that just got a shift report, and they say that you're having a hard time with having some abdominal pain. Had started out kind of diffuse, but now it seems to be locating in your right lower quadrant. So let's hear from you, Mr. Bryant.
Hi, I'm Mr. Bryant, and I'm at the Parkland Hospital, and I don't seem to be feeling very well.
Okay.
I've been having abdominal pain for the past couple of days.
Okay.
With nausea and vomiting, and now I have diarrhea.
Not so good.
The pain seems to be getting worse. It was all across my abdomen, but now it seems to be locating in my right lower quadrant.
Okay.
I'm feeling worse. I don't know really what's going on. I'm hoping they can help me here at Parkland Hospital.
Well, yes, Mr. Bryant, we can certainly help you here at the Parkland Hospital. You've come to the right place. So let's review your symptoms now. For the past few days, you've been having more or less diffuse abdominal pain going across your abdomen. Is that correct, Mr. Bryant? Yes. Now you seem to be having pain located in your right lower quadrant. I understand too that from report you've been having nausea, vomiting. Now the abdominal pain that's locating to the right lower quadrant. Not feeling very well. You're also having some diarrhea as well, and also running a fever, and just not feeling very well. So I'm glad you've come to Parkland Hospital because I know that we can help you. I know that the emergency room did some blood work on you. It is showing that your white blood cell count is indeed elevated. It's about 15,000, so that's a little higher. So we do believe that you do have some type of an infectious or inflammatory process going on, and I think we may do a CAT scan in a little bit to see if that will help us diagnose this. We're wondering if you are not having a bout of appendicitis, because as we know, appendicitis is an inflammation of the appendix, which is in your bowel, and sometimes that can become inflamed and become infected, and people will get what we call appendicitis. So we'll do a CAT scan, and we'll take a look at that to see if that does indeed show the inflammation of the appendix. Oh, well, look at this. We do have your report back, Mr. Bryant, and it does indeed show that you are having an inflammation of the appendix. So we do believe that you are having appendicitis. Let me press in on your right lower quadrant at McBurney's point. Tell me how this feels. Oh, okay. You have more pain when I lift up my hand. So I'm pressing on the right lower quadrant. When I press in, you seem to be okay. But yet when I relieve my hand off of your right lower quadrant, you have pain there at that McBurney's point. That's also rather indicative of someone having appendicitis as well. So your CAT scan is showing inflammation of the appendix, so I really think that we need to get you to surgery because we would like to get that appendix taken out before it, of course, bursts. If it does burst, then you can get a much worse infection called peritonitis, and that can get kind of bad, kind of fast. So that's why we don't really want that to occur. You will obviously need to be on some IV antibiotics before and after your surgery, for at least for a little while, and you'll probably go home on oral antibiotics as long as we can get to your appendix before it bursts. Okay, so, all right, well, hi, Mr. Bryant. So this is now after surgery. time moves rather quickly here at the Parkland Hospital because we're having a lot of fun. Anyway, Mr. Bryant, you had your surgery. Wow, that is awesome. So we were able to get in there, and the doctors were able to get to that appendix before it burst. So that's really wonderful news, Mr. Bryant, because as I said, if we didn't get to that before it burst, it can cause an inflammation and infection of the peritoneum, which is a lining of your abdominal wall. If that becomes infected, it can get very serious. People will complain about having even worse abdominal pain than what you were having with your appendicitis, a tender board-like abdomen, and a fever, nausea, and vomiting, and just overall feeling pretty bad. So we do need to treat that with some high power IV antibiotics to get rid of that infection, because of course we don't want that infection to get into your bloodstream. So peritonitis is an inflammation of that peritoneal lining that lines the abdominal cavity as well as most of the organs. And sometimes we know that can become infected, maybe either from ascites, people that have ascites from cirrhosis of the liver, or in this case, having the appendix rupture, having diverticulum rupture, can all lead to the infection of the peritoneum. So that's what we're hoping to prevent here. So I'm really glad that the doctors were able to get to you before your appendix burst, and we can prevent peritonitis from occurring. So now, as you are recovering, we do want you to be coughing and deep breathing and getting up and walking around. I know they were able to do your appendix surgery using a laparoscope. That's awesome, because we know that people heal much faster and quicker from a laparoscopic surgery versus a laparotomy or an open incision surgery. So that's wonderful, although people can still have complications such as DVTs and ileus, even though it was done laparoscopically. But generally speaking, people usually do really very well after having a laparoscopic surgery. So you should be able to go home later on this evening, as my son was able to go home the same day of his appendix surgery, and he had appendicitis when he was a sophomore in college. And he was having diffuse abdominal pain that did finally localize in the right lower quadrant. Blood work did show, indeed, I think his white blood cell count was all the way up to like 20,000. He was having vomiting, diarrhea, and really just not feeling very well. So as a matter of fact, Dr. Craddock did not even have to get a CAT scan. She said, I am sure that this is what this is, so let's just get him into surgery and get it before it ruptures. So he had surgery about 4 o'clock in the afternoon. I think he was out of surgery by 5 in the recovery room, and by 8 o'clock he was on his way home with my husband, his dad, and he was going to take him home, and my job was to go get him something to eat for supper post his appendectomy 4 hours prior, and he chose Neros Gyros. So not sure maybe that was the best choice, but I think he did eat at least one of them when he got back home. So I'm not sure I would suggest that to everybody, but he was a trooper, and he even went back to playing soccer like the next week. So anyway, and he was able to have his surgery done laparoscopically as well. So yeah, so very good, Mr. Bryant. I'm really glad that you have recovered from your appendectomy surgery. So I mentioned, I believe I mentioned this a minute ago about diverticulum. Mr. Bryant, have you ever been told that you have diverticulum? Why, I hope not, since you just had appendicitis surgery, but some people will have diverticulum, which are outpouchings of the intestine. That area is weakened, and then people who are not eating a lot of fiber in their diet, the intraluminal pressure increases, trying to get the stool through the bowel, and these sacs can then herniate, or they have an outpouching, and those sacs are called diverticulum. Mr. Bryant told me earlier that his brother has had some diverticulum with some diverticulitis, so he's kind of curious. So we're just going to educate Mr. Bryant so he can help his brother. So we are all about helping each other. So at any rate, so these sacs can sometimes become inflamed and filled with food and become infected, and sometimes the diverticulum can go on to be something called diverticulitis, so an inflammation infection of those sacs, of the diverticulum in the bowel. So we can treat those with IV antibiotics, and usually if we can get to them early enough, maybe treat it before they do, again, before they burst. Diverticulum can burst that are infected and again cause a severe infection called peritonitis, which again, then people can go on to develop sepsis, which is really what we hope to prevent here at Parkland Hospital. So, yeah, so diverticulitis, treated with IV antibiotics, probably an NG tube to let the bowel rest, nothing by mouth, IV fluids, IV antibiotics. And once they are able to start eating, they are going to start out on a low residue or low fiber diet because we want that bowel to heal from, if they have to have surgery done because of diverticulitis, in many cases people do. So we'll treat with IV antibiotics both before and after surgery. And as they are able to start eating, we'll start them off on clear liquids, of course. And then again, a low fiber or low residue diet. We don't want things going through the bowel that's going to cause irritation because we want that bowel to heal, of course. Now, if they have ruptured, again, IV antibiotics and surgery usually is indicated, again, like I said. But this is considered any surgery in your, with concerning your bowels is going to be, quote, a dirty surgery because there's, as we know, there's a lot of bacteria in our gut, which is good. We need that bacteria, of course, for digestion and elimination. But when we do surgery on these patients, that bacteria can go other places. And so what you will see a lot of times are people's midline incisions will dehiss or open up. If that indeed happens, and actually I see it happening really quite a lot, although I don't think I've seen it this semester as of yet. But at any rate, it does seem like it happens, fairly often. So what they will then do is, generally speaking, they will go ahead and just pack with normal saline dressings and change those maybe 2 or 3 times a day. The other thing that they can do that is proven to be very useful is place a wound vac on that abdominal midline incision. And wound vacs have been around for probably 15 to 20 years. They do show that they decrease length of wound healing. So a lot of times they'll leave those open, let them heal from inside out, use a wound vac or normal saline wet to dry dressing. So, that can take a couple of months. And sometimes when people do have to have surgery for diverticulitis, they will have to have an ostomy, again, more or less for bowel rest. But generally speaking, after maybe 4 to 6 months, once everything is kind of simmered down and has healed, then they will go in and do what they call a takedown of that colostomy, so that they will reanastomose those 2 ends of the bowel, and then the patient will be able to defecate as usual. So we see that, like, again, a fair amount. So Mr. Bryant, I hope you have received this good information to use so you can talk to your brother about this. So, yes. So now what else, Mr. Bryant?
Hi, this is Mr. Bryant again, and I now seem to be having difficulty with my bowels, and I think they are talking about that I may have either Crohn's disease or ulcerative colitis. I don't really know what those diseases are all about. I just know that I'm not feeling very good and just having a lot of cramping and a lot of abdominal pain. Hope they can help me here at the Parkland Hospital.
Well, gosh, hi, Mr. Bryant. I am Dubuque, and I'm the nurse here at the Parkland Hospital taking care of you today. So, yes, so I understand you've been having some abdominal pain and, cramping, a lot of cramping, so you're not able to eat very well. You haven't been able to eat very well for quite some time. You've lost some weight. You've also noticed that it looks like some oil has come to the top of the toilet whenever you have a bowel movement and your stools are loose. You're having lots and lots of loose diarrhea stools every day, and just the cramping, abdominal pain, and it just doesn't seem to be getting any better. So so Crohn's disease and or ulcerative colitis are both known as inflammatory bowel diseases. Crohn's disease can affect all layers and all along the GI tract, where ulcerative colitis is more in the left lower quadrant, and of your ulcerative colitis generally affects like your colon, bowel. So the treatment, usually they will do, as far as diagnosing, they will probably opt to do a scope, a colonoscopy, so they can directly visualize what is going on in your bowel, and then they can take tissue samples as well to see what that shows. So that's how they generally diagnose Crohn's disease or ulcerative colitis, is with a colonoscopy. And also looking at your blood work. Crohn's disease, we do see the oil or steatorrhea is what we refer to that. We do see that a lot in Crohn's disease patients, and again, they have malabsorption because they are having so many diarrhea stools, and they don't want to eat because they're having a lot of nausea and vomiting, and as well as, of course, the loose stools. So they generally come in showing, malnutrition, and because they've not been able to really eat and drink very much. So Crohn's disease is more of a cobblestone appearance on a scope. It is not continuous, red irritation of the bowel. That is what ulcerative colitis will look like, where Crohn's is just like a cobblestone appearance, and it's like these yellow areas that you'll see, and then you'll see good bowel, and then you'll see the Crohn's, and you'll see good bowel. Where ulcerative colitis is just a red inflammation of the bowel, and it's continuous, and it looks like I said, pretty red and inflamed. So to treat ulcerative colitis and or Crohn's disease, there are different medications that can be used for both. And as a matter of fact, there is a good drug chart on page. It's in your book, like 974. I'm not sure I'm going to be able to find it here, but anyway, there is a good drug chart. I will not go into all the different drugs, but you will want to go over that drug chart. It does show a lot of the different drugs that are that are used in both ulcerative colitis and Crohn's disease. So now sometimes as this worsens, people will indeed need to have surgery done. Surgery for Crohn's disease, as they remove portions of the bowel, and particularly the small bowel, they can get what's called short bowel syndrome, because they've had to have so many times where the surgeon goes in and has to cut out the disease portion of the bowel and connect it back together again. So they really don't like to do that, because with short bowel syndrome, they're just really not absorbing much of anything at all. So really having a hard time keeping up their nutrition. So so they try not to do surgery if they don't have to. Sometimes they will need to remove maybe all of the colon, and they'll end up with an ileostomy, which we can sometimes see with patients with ulcerative colitis as well. If they have to have surgery, many times they just remove the whole entire colon. And as a matter of fact, and they may need to have an ostomy, an ileostomy. But generally speaking, Crohn's disease, if they have surgery, again, because it affects all of the GI tract, right? So we generally cannot cure Crohn's, but ulcerative colitis, if we do surgery and remove the whole entire colon, then we can actually say that this person has been healed of their ulcerative colitis. If they do have an ileostomy placed, an ileostomy is a little different than a colostomy. Colostomy is where you'll have soft stool coming, where ileostomies, because of where they are, patients will have really tremendous and copious amounts of fluid, stool out of those ostomies. So we do need to really educate our patients on having good hydration, particularly in the summer months, because they can become dehydrated really quite easily. So we need to keep an eye on those patients with ileostomy. So anyway, and while they're, first of all, when they're in exacerbation of ulcerative colitis and or Crohn's disease, you do not want them having foods with high fiber, because their intestines and bowel are already very irritated, and so you don't really want to irritate them even further. So we recommend a low residue or low fiber diet if they are able to eat. Otherwise, actually, they may need TPN for a while to build them up nutritionally wise before they maybe even consider doing surgery. So low residue diet while they're healing. Once they get past that, and same way, by the way, with diverticulosis, that's usually caused from a low fiber diet. So while they're having an attack of diverticulitis, excuse me while I go back here, but If they're having an attack of diverticulitis, they will also be on a low residue diet. Once the diverticulitis heals, then they will be on a high fiber diet, just like with inflammatory bowel disease. Once they heal, get over their exacerbation or maybe surgery, they'll start with a low fiber, low residue diet, and then eventually they will be able to go on and take in more fiber, and adjusting that according to how they're feeling and how they're doing. So that's inflammatory bowel disease in a nutshell. And let me see if Mr. Bryant has anything else he wants to say here. Let me see.
So this is Mr. Bryant again, and I've been noticing a change in my bowel habits over the last 3 to 4 months. And now they're kind of like my bowels. When I have a bowel movement, it's like about the size of a pencil or a pencil eraser, and I'm having a hard time. I don't feel like I'm able to pass on my stool. I'm having abdominal pain, and I did notice a little bit of bleeding in the toilet this morning after I went. So thinking I need to go contact my doctor. I know that sometimes people can have colon cancer. I hope that's not what it is, but if it is colon cancer, I hope that they can catch it early so that I can do very well. So again, I'm here at Parkland Hospital, and I sure hope they can help me again here. Thank you.
So Mr. Bryant, the poor guy, he's just really having issues with his GI system here. So, but we appreciate him allowing us to talk to him and see how he's doing. So he's had a change in bowel habits, and actually change in bowel habits is one of the most common signs that a patient may be having difficulty with possibly colon cancer. So we need to educate the public that if they do have a change in bowel habits, they really need to get checked out as soon as they can, because if we can catch colon cancer early than late, then they have actually a really high rate of being able to do very well and have it cured even. But again, we need to find it in the early stages. And so risk factors can be people over the age of 50, family history of colon cancer, people with polyps, people with a high-fat, low-fiber diet. People who have inflammatory bowel disease are also at increased risk of developing colon cancer as well, such as your ulcerative colitis and your Crohn's disease. So those things, and alcohol consumption, can all contribute to developing colon cancer. And of course, colon cancer will cause a growth in the colon, and people will see a change in their bowel habits because there's a stricture there where that mass may be. There's a stricture, so patients have a hard time defecating and expelling all the contents from their from their bowels. So generally speaking, they will do a colonoscopy there again. You can get visualization, good visualization, and polyps. Actually, history of polyps is actually an increased risk for having colon cancer as well. So they do colonoscopies starting at the age of 50. And generally speaking, if everything is going well and there's no family history, they can bump them up to every 10 years. But if there's a family history, then they're probably going to go ahead and keep them on a 5-year schedule, because it's been shown that polyps can lead to cancer, and if we can catch polyps early enough, remove them, then we can decrease the patient's risk of cancer. Now, if they have very many polyps, then they're probably going to need surgery to remove those. And or if they do find indeed colon cancer, then they will need to do surgery where they resect that diseased bowel, and hopefully be able to reanastomose it so they don't have to have a colostomy. Sometimes they do. So my dad was diagnosed with colon cancer, I believe, when he was 72. Unfortunately, his was stage 3, so it had extended out beyond the colon. And I don't recall if he had any lymph node involvement, but he actually had surgery done. I think they removed a little over a foot of his colon. They were able to reanastomose his bowel. He did not have to have a colostomy done, which was, really good. We were very thankful about that. They didn't have to worry about that. But he healed after his surgery. Did really quite well. Did chemotherapy. I think it lasted about 6 months, and he did really well with chemotherapy too. He would even go out and put around in his shop where he liked to work on lawnmowers and cars and whatnot. So he did very well, after chemotherapy. And actually, he never did have he was in remission from the time they did surgery. He never did have a recurrence of colon cancer. So that was, quite remarkable at age 72 in stage 3 in, cancer to boot. And as I said, sometimes if it is extensive and maybe having rectal cancer, that's when they may have to remove the rectum and part of the bowel, and where people may have to have a colostomy done. So these patients that have ostomies, either colostomies or ileostomies, they need to be taught before they leave the hospital, them and their caregiver, the patient and their caregiver, on how to care for these. The first thing is you want to observe the skin around the stoma. The stoma is where you can see the intestine coming out, and they bring it out on the abdominal wall, and then of course it empties into a bag, an ostomy bag. And depending on where it is, colostomies, the stool will be soft. Ileostomies, the stool will be very liquidy. So again, we worry about hydration for these people. But good skin care. The intrastomal nurse will go over patients and direct them on the appropriate care. Many times they will recommend first of all cleansing off the area with soap and water. It's really important to get soap that does not have a moisturizer in it, so the appliance will stay on. So they clean it off with really good, or soap and water, or warm water anyway. Dry it well. They may use skin prep around their skin, and then they cut the appliance that will fit over their stoma, the right size, because you don't want to leave a lot of skin exposed, because it'll get irritated and reddened. So you will put the the appliance on and put the bag on, and then so some people it will be recommended that once they put the appliance on, they'll add some paste and then some powder that helps with the seal. People that have a hard time with the seal, if they're not doing that, they may recommend that they do that. Now, not everybody has to do that, but that is kind of typical for stomal care. So some ostomies can be really, really difficult to manage and to get the right size and the right type of appliance on there. I took over a patient that had a couple ostomies several summers ago in my home care practice, and she just had an awful time pouching her ostomies, to the point where I called Nancy Bolero, and Nancy Bolero actually made a couple of home visits out there to see her and to get her fixed up, and she did eventually get her fixed up. Unfortunately, she did pass away. She had a lot of colon cancer, and I think maybe even ovarian cancer or something, but she passed away maybe about 5 or 6 months after that summer that I was taking care of her. But Nancy was able to get the right appliance and the right bag. So there's so many different types of appliances that are made now for people with ostomies. So if one doesn't work, there's so many others that they can try. And also referring somebody to an intrastomal nurse such as Nancy Bolero really does help and make a difference in making those decisions as well. So anyway, so that's kind of a rundown of some lower GI problems that people experience. So, well, Mr. Bryant, we are really glad that you were so gracious to be able to let us come and talk to you and care for you here at the Parkland Hospital, the Exceptional Superior Profound Hospital Network, of course, starring Mr. Bryant as well as myself, Dubuque. So thank you for attending this class from the ESPH Hospital Network. No worries, we will be bringing more episodes to you, I'm sure. Thank you. And thank you, Mr. Bryant. You again are totally wonderful and awesome. We appreciate your willingness to help us out. See y'all later at the next class.